Pre-labor rupture of membrane. What is pre-labor rupture of membrane? From the name, it is a rupture of the amniotic membrane, okay, before the onset of labor. Before the onset of labor. So it is pre-labor before the onset of labor, rupture of membrane. This pre-labor rupture of membrane may be term or preterm. What do we mean by preterm pre-labor rupture of membrane? We mean that rupture of membrane that occurs before 37 weeks, okay, before 37 weeks, before term, so it is preterm, okay. In the past, they used to use, some books used to use PROM as premature rupture of membrane, okay, but nowadays the used concept is pre-labor rupture of membrane, not to be confused with preterm and term rupture of membrane, okay. So what is a prolonged rupture of membrane? It is more than 24 hours rupture. In Canada they use more than 18 hours, okay, to prolong rupture of membrane. In other places they use more than 24 hours, okay. So this is the definition of pre-labor rupture of membrane. The most important problem about rupture of membrane is, or premature rupture of membrane, is infection, especially chorioamnitis. So mostly this is the cause behind preterm labor and premature or pre-labor rupture of membrane. Because of infection, they mostly deliver early, okay. What are the complications of pre-labor rupture of membrane? Okay, could be term or preterm, as we said, okay. The complications, let's start one by one. Infection like what? Like Neisseria infection, group B streptococcus, okay. The most infection is chorioamnitis. Chorioamnitis is the most used infection, okay. So this first complication, infection, cord prolapse, okay, and abruptio placenta, especially if we have polyhydramnios, for example, and sudden rupture of membrane. There will be a sudden decompression of the cord, okay, and it will be abruptio placenta. So these are the most important three complications. Also we have oligohydramnios due to leakage of fluid, and oligohydramnios will lead to pulmonary hyperplasia in a lot of cases. Why? Because the amniotic fluid is beneficial for the development of lung, okay. So we have pulmonary hyperplasia if we have oligohydramnios. We will have incomplete alveolar development also. By the way, we are talking about amniotic fluid. What are the sources of amniotic fluid? The sources of amniotic fluid mostly is from fetal urine, okay, but also a small amount of amniotic fluid is from saliva, from pulmonary fluid, okay, from the lungs, so diffused from the skin, from the tissues of the baby, okay, mostly above 16 weeks from the fetal urine. What is the function of the functions of the amniotic fluid? They protect the fetus from infection, from trauma, and they protect them from umbilical cord compression, okay. Fetal movement and breathing is two of the functions of the amniotic fluid. So a lot of functions, okay, and a lot of sources of amniotic fluid. So let's get back to our subject, okay. The complications of pre-labor rupture of membrane, okay, infection, abruptio placenta, cord prolapse, oligohydramnios. Okay, now let's move to the presentation. How does it present the premature or pre-labor rupture of membrane? Mostly it presents as a gush of fluid from vagina, okay. It's a gush of fluid from vagina with subsequent continuous dripping, because the rupture will still rupture, and we will still have fluid dribbling, okay, after the main gush of a fluid. You have to analyze this fluid in history, the amount, the color of fluid, the smell of fluid, the amount again, the timing of fluid. Or was it when she was a bathroom, for example? Is it after sexual intercourse? Okay, or other things. About the color, I want you to take care that the yellow color indicates urine. Okay, it may be urine, maybe not a liquor. Okay, for example, in urinary incontinence, or if you have vesicovaginal fistula. Okay, if we have red fluid, maybe blood. Okay, due to a rupture placenta, for example, or an trauma, infection, laceration. Okay, anything. Green is meconium. Green is meconium, and here we have to take care because meconium is an implication of fetal distress, and we have to deliver the baby immediately. Also, you have in history to ask about differential diagnosis. What are the differential diagnoses of rupture of membrane or fluid leakage? Maybe urine, as I said, urine incontinence or urine fistula. It may be normal increased vaginal discharge due to normal physiological pregnancy. In pregnancy, vaginal discharge will increase. Okay, so it may be increasing vaginal discharge. It may be vaginal and cervical infections. Okay, so this fluid may be a discharge of infection. Maybe liquor from rupture of membrane, or maybe urine due to any cause, and other differential diagnosis. Now let's move to the physical examination of a patient that comes to you with rupture of membrane, okay, or with the fluid leaking. We will start, of course, with vital signs, because the most important underlying cause or risk factor for premature rupture of membrane is infection, chorioamnitis. So in vital signs, we will notice if the temperature mostly to see do we have chorioamnitis, okay, or any infection. Also heart rate and pulse will be beneficial in this case to know any signs of infection. Okay, now after vital signs, general examination, and that these things, we move to abdominal examination. What do we need to see in abdominal examination? Okay, we have to notice tenderness. Okay, do we have any tenderness? Because tenderness implicates an infection, okay, or maybe a ruptured placenta. Okay, do we have contractions? And you will see in management that patient with contractions is managed differently from patient with no contractions. Fundal height, okay, because fundal height in rupture, most of cases of rupture of membrane, it will be decreased because of oligohydramnios. All fluid will be gushed, or a load of fluid will be gushed. Okay, so we'll have decrease in fundal height, and this is an implication of rupture of membrane. So tenderness, fundal height, contractions, and speculum examination. Here we have to stop. Okay, in pelvic examination, after abdominal examination, the first thing to look at is speculum examination. This is the most important among all physical examination, because what? Because it is a confirmative examination to be done. Okay, it confirms diagnosis. How? You have to ask the patient to sit 10 to 15 minutes, okay, to descend the fluid down. So ask the patient to sit 10 to 15 minutes, then insert a sterile speculum. What things you want to notice is a fluid pooling in the posterior fornix of the vagina. Do we have fluid pooling? If yes, we have fluid pooling, that gives you a good indication that we have rupture of membrane. If you see a fluid gushing from the external os of the cervix, then this is diagnostic for rupture of membrane. Okay, so we have to notice, do we have a blood, do we have a mucus, do we have cord there descent? We said that Rupture of membrane is associated with cord prolapse as a complication. Okay, so in physical examination we have to know, do we have a cord that is a prolapse, because it's a dangerous condition. We have to monitor and treat. Okay, this is all about physical examination. Vital signs, you look for infection, abdominal examination, tenderness, infection, fundal height, contractions. Okay, in pelvic examination, speculum examination, the most important, see pooling of fluid gushing from the external os or not. Okay, blood, mucus, cord descending. Okay, is also important to see. Digital examination and pelvic examination is not to be done. Okay, because it will introduce an infection in women without amniotic fluid. Okay, without membranes. I'm sorry, because as I told you that amniotic fluid and membranes helpful in preventing infections. Okay, now let's move to the investigation should be done in fluid gushing or premature rupture of membrane. The first test is nitrazine test. What is nitrazine test? It is a test that used to distinguish acid from bases. Okay, so we put the vaginal secretions on the nitrazine paper. Okay, if we have a rupture of membrane, then we will have alkaline media, because amniotic fluid is alkaline. Vagina is acidic. Okay, most of the time. So vagina pH is around 4.5 to 6 normally. Okay, if you put amniotic fluid on it due to rupture of membrane, then it will be alkaline. The media will be alkaline, and nitrazine test will show you dark blue color. If it still yellow on nitrazine test, then it is acidic, so we have no amniotic fluid or little amniotic fluid. Okay, in false negative values, it may be false negative due to small amount of amniotic fluid. It will not discover it. Okay, so when do we have false positive values of nitrazine test? It may be due to blood. Okay, their blood or base urine. Okay, it may be urine that made the nitrazine test dark blue. Maybe semen, exogenous source, or in some infections like a trichomonas infection. Okay, trichomonas infection will convert the nitrazine paper into dark blue. Okay, when do we have false negative nitrazine test? False negative means that we have false value, okay, we have negative value, but we still have rupture of membrane. If we have a small amount that is not enough to make the media alkaline, okay, we may have false negative values. Fern test is second test to do. In Fern test, we have to we can see pattern of arborization on microscopy. Okay, so we take the vagina cervical secretions and put them in the slide, and we dry these slides in room. Okay, and we will see this pattern. Okay, so this is positive Fern test for amniotic fluid. Then we have to do ultrasound to say the amniotic fluid index. If it is lower than 5, then we have oligohydramnios, and that indicates that there is a rupture of membrane. Okay, in ultrasound we see live presentation to know how to deliver the baby, if we have to deliver the baby. Okay, we do genital tract swab to see a group B streptococcus. Also, maternal well-being is important to investigate by vital signs, white PCs, C-reactive protein, to see if we have any infection. Okay, and contractions, we have to monitor contraction. Fetal well-being also is important to do non-stress tests. Bradycardia, because in bradycardia we have a chorioamnitis as a cause, and sometimes. Okay, also in fetal well-being we have to note if there is any deceleration, because most deceleration in the premature rupture of membrane is a variable deceleration due to cord prolapse and compression. Okay, So these are the most important investigation to do: nitrazine test, fern test, ultrasound, genital tract swab for an infection, and maternal and fetal well-being. They used to do amniocentesis, but nowadays it is not do because it is invasive. They used to insert carmine dye into the uterus, and if it descends from the vagina, the carmine dye, it is blue dye, then we have a rupture of membrane. Okay, now it is not used anymore because it is a source of infection, it is very invasive, and it is not used. Okay, thank you very much for watching. Thank you very much for watching. Again, see you in the next video.